السلام عليكم ورحمة الله جميعا. I would like to make sure that you hear my voice. Can you just reassure me that my voice is heard? Very good. السلام عليكم جميعا. أهلا وسهلا فيكم. It's a pleasure and an honor to meet all of you. It's a wonderful chance to see all of you again. It's been a while, and many of you we've had a lot of contact before, and today it's a very happy day for me. It's like to start this interaction with all of you. And today we're going to start medical education, and we try to name it Without Borders because that's what it is. Zoom allows us to do so. And I think it is a very good opportunity to see education that happens across borders everywhere. We have a lot of good people that are willing to help, like Dr. Jamil Farra today, and so many others that we also got into communication with, to make sure that we have a program that usually our aim is for it to last for a long time and becomes constant. So with you as members of this, and hopefully we'll continue together to see the future. Number one, I would like to, it's unfortunate times with this unusual event of the coronavirus and the COVID-19. Hopefully everyone is safe. And second thing I would like to say is Ramadan Kareem, inshallah يتقبل منا ومنكم صالح الأعمال. And for that reason, our times are going to be at 10 o'clock on Wednesdays. There are other programs that I'm intending to start bi'Iznillah. There are other speakers that are very happy and eager to start. So we might have another session running on besides this Wednesday session. Okay, so our programs is going to be weekly, as we mentioned, and during these period of time, we're going to have lectures. The registration form was sent to everyone, and everyone shared in it, which is very good. And we have some speakers now from the recommended speakers by you as well. And this is also something that we're gonna look into, inshallah, and schedule and try to communicate with them. Without further ado, I would like to introduce my colleague and friend, Dr. Jamil Farra. Dr. Jamil Farra is a consultant in maternal fetal medicine in the US, and you've seen his CV, and I'm sure that probably most of you knew him when he was in Saudi, back in Saudi. He left around 10 years ago. And hopefully he's willing to join us for the next few weeks to give us a few lectures about maternal fetal medicine. And I hope, and I'm sure that you're going to enjoy and learn a lot. In regards to what happens during the talk, Dr. Jamil is going to always take a few minutes to pause, and then I'm going to moderate this by looking at the questions and then we look at the questions written in the chat, and whenever we're required, we're going to open the microphone for whoever wants to speak. So you can raise your hand. So Dr. Jamil, the floor is yours. You can share your screen now.
Perfect, excellent. So just to give you a little bit of a brief background. So like Dr. Badr said, I'm a maternal fetal medicine specialist, but also what I do is for the last 12 years, I have actually been helping medical students pass the USMLE exam. I have also been helping residents pass the board exams, whether it's oral or written. So when I look at, lectures in general, there are two things that I look at. Number one, it's making sure that everybody understands and everybody knows what is going on. Number two is to also make sure that I help you understand what could potentially be asked in an exam. Now, my aim always in any lecture that I give is I always concentrate on understanding, because a lot of times what I notice is a lot of people will memorize a lot of things, and whilst memorization is good, it can sometimes take a long time, but when you understand a concept, it makes it much, much, much easier. Now, IUGR is a topic, unfortunately, that does not have a lot of consensus. There is still a lot of debate, a lot of back and forth. So what we're going to do is kind of talk about it briefly overall. And then after that, I'm going to tell you what's debatable and what's not. I'm also going to go over what Dopplers are like and how to interpret them and what to do with them. Okay. Are you guys ready to start? All right. We're going to have a lot of fun today. This is going to be a very informative, nice lecture. I like a lot of interaction. I like you guys to participate. Now, this lecture is a little bit different because I'm not used to giving lectures from home. I'm usually giving the lectures either in person or in the office. But of course, the circumstances now are not what we are used to. So I hope that God, clears the... Does anybody know? So first of all, what I want you to know is IUGR is an ultrasound diagnosis. So you can't make IUGR without doing an ultrasound. And you do an estimated fetal weight. And based on the estimated fetal weight, you decide whether this baby is appropriately grown, small, or large. Where the consensus is not there is what is considered IUGR. So I'll give you an example, right? If I do an ultrasound and the baby is below the 10th percentile, can I truly and always say this is IUGR? The answer is absolutely not, because before I do that, number one, I have to make sure that I have accurate dating. Number two, right, if I have accurate dating, that's good. But then let's say if we look at a baby's growth curve and the baby was at the 60th percentile, the 90th percentile, and then it started dropping, but it didn't go below the 10th percentile. Is that baby fulfilling its potential? So is that more worrisome for me, for instance, than a baby that is less than the 10th percentile, but throughout the pregnancy is continuing to grow? And hence where these are the gray lines that we have to tackle with IUGR. And see, that's what makes it complicated. However, the American College of Obstetrics and Gynecology recommendations right now are to consider IUGR anybody below the 10th percentile, okay? And that's gonna be the definition that we're gonna use throughout this lecture. But as human beings, as physicians, as doctors, we always have to be cognizant. If you have a diabetic mother that is poorly controlled, and then the baby's also, at the 20th percentile, is that what you're truly expecting from a diabetic mother? That could be more concerning. If you have a patient that is, 1 meter and 40, 1 meter and 40, centimeters, and she has a small baby, and she tells you, look, I've got 5 babies at home, all of them were small. Is that as worrisome? Okay, and that's kind of the introduction that I wanted to give. So let's move on for the time being, okay? So what is macrosomia? Macrosomia is defined as a fetal weight above 4 kilos. What is a low birth weight? It is a newborn weighing less than 2.5 kilos. And see, the difference is these are birth weights. After the baby's born, you can weigh them. Estimated fetal weight is before the baby's born, right? And a macrosomic baby, while the baby is still inside, is above the 90th percentile. An IUGR baby is less than the 10th percentile. Okay. So, like I said, there is no consensus of opinion on the above definitions. However, for this lecture and what I use in the office and what we use as colleagues right now is below the 10th percentile. The dilemma, this does not account for normally grown fetuses not achieving their potential, okay? And keep that in mind, always. That's why when I see patients in the office, I look for patterns. If the baby started out at the 70th percentile, next ultrasound the 50th, next ultrasound the 30th, I start to watch out for that baby because I am generally concerned and worried. So the first thing to consider in the evaluation is the accuracy of gestational age. Now, I'm gonna pause for a minute here and I'm gonna get consensus from you guys. What are some of the ways and methods for estimation of gestational age? What do we use? What are our traditional ways of doing that? Okay. Perfect. So we have the last menstrual period, as I can see, all right? You also have ultrasound. And then what makes you decide the better EDC is the difference between the last menstrual period and the ultrasound. Also, other factors that play a role. Does the patient have regular periods? Is she sure of her period? Was she breastfeeding? Was she, using contraception. So all of these weigh in. And then the American College has a nice little table based on gestational age. It tells you what to choose. And it's based on the discrepancy between the ultrasound and the last menstrual period. Now, in general, which ultrasounds are more accurate? It's the ultrasounds that are done earlier on. So if I had ultrasounds, right, a crown rump length is definitely better than a 20-week ultrasound. All right? And so forth. And a 20-week ultrasound is better than a third trimester ultrasound. So we allow more differences between the last menstrual period and ultrasound the further the gestational age goes. So in the first trimester, I may allow 1 or 2 days, 3 days, 4 days. In the third trimester, I may allow up to 2-3 weeks. Okay, now here's the deal, right? Now that's an exam question. What is the most accurate way to determine the EDC? Does anybody know? The most accurate way. And this is a sneaky question. All right, I will give you the answer. It's actually if somebody had IVF and underwent an embryo transfer. And this is actually written in the books. If you have an embryo transfer, isn't that the most accurate way of knowing when the conception date happened? Absolutely. Then after that, in the first trimester, it's always going to be a crown, a crown rump length, right? Now, till what gestational age can you generally do a crown rump length? Roughly, give or take. Yeah, you can do a crown rump length up to around 14 weeks. Or if you wanted to be more specific, okay, it is based on millimeters. And the actual cutoff for millimeters in a crown rump length is 84 millimeters. And the guidelines are clear. If you measure the crown rump and it's more than 84 millimeters, then you should use the regular biometric measurements, such as a head circumference or a BPD. Now, also keep this in mind as well. In general, when we get an estimated fetal weight, okay, we use the head circumference, the abdominal circumference, the femur length, and so forth, correct? But if you had to pick one of these measurements, the stomach, right, is not very accurate because it's easily squishable, and also in IUGR, it could be the one that actually decreases the most. So it's actually a bony, it's a bony structure, and it depends on if the head is regular or irregular. If the head is regular, then the biparietal diameter is the best. If the head is irregularly shaped, then a head circumference, okay? See how it's all making sense? And when you look at these, right? I have somebody, I do an ultrasound, right? So let's kind of go into a scenario. And as you can see, as much as I love having PowerPoints and slides, I feel the best way to talk is we will go back to the slides, but the best way to talk is to just discuss these things, right? So what usually happens in an IUGR baby, right? A patient comes in for her prenatal visit and the doctor is doing a fundal exam or a fundal height. And they're like, you're supposed to be measuring 28 weeks, but when I'm doing my fundal height, this baby is smaller than what I expect you to be. So then what does the doctor do? They go back, they look at the last menstrual period, they make sure that their dating is accurate, they see if they have an early ultrasound and so forth. And then they also see if there is anything else that could potentially, right, make the fundal height discrepant. So that's another multiple choice question point. The most common reason for a discrepancy between the gestational age and the fundal height is incorrect dating. All right? Then there are other things, right? What if this is 2 babies instead of 1? Don't you expect the fundal height to be different than the gestational age? Molar pregnancy, polyhydramnios, right? What about uterine fibroids? See, it makes sense. If I have a fibroid, isn't the fundal height going to be higher than the gestational age? If I have 2 babies, isn't my fundal height going to be big? Molar pregnancy, polyhydramnios. So then what happens? This doctor says, the fundal height and the last menstrual period, they're not going together. So what am I going to do? I'm going to do an ultrasound, right? Now, if this is the first ultrasound, then it may be the one that is used for dating. If it is not the first ultrasound, then your first ultrasound is going to serve as the benchmark and the comparison for the next ultrasound. So let's assume we do an ultrasound and you're looking at the report and the estimated fetal weight is less than the 10th percentile. Let's say the estimated fetal weight is at the 6th percentile. What are some of the things that you need to now consider, right? You're sitting there and you're going, what could cause this baby to be small? So there are 3 things in general, right, that can make a baby small. And the way that I look at it, right, for a baby to grow well, it needs the maternal blood vessels to be healthy and good. It needs the placenta to be good. And it also needs a baby to intrinsically have the ability to grow. See, pipes need to be working. Placenta and the umbilical cord needs to be doing well. And the baby has to have the potential to grow. So if we start from the baby, what are some of the things that can make the baby small just within the baby, right? Maybe constitutionally, right? That's just the baby's growth potential. Could there be an anomaly? So then the next step is definitely going to be, let's do a detailed anatomical survey of this baby. Let me see, is there something that will explain the IUGR, right? Then after that, right, we're going to look and see if there is normal or abnormal blood flow. Then we're going to review the patient's history. Okay, if I tell you this patient is a long-standing diabetic for the last 15 years and she's a type 1, you're like, the plumbing is probably not good. If she is also a hypertensive. So see how now none of this is memorizing, none of this is memorization, it's all about understanding. Now, could there have been an insult on this baby early on? Could have this baby gotten a medicine that it shouldn't have, or exposed to radiation, or as I saw a lot of you have put in there, could have an infection gotten to that baby? Could the mom be a smoker? Absolutely. But see, the common thing is you're always working as a detective, right? Whenever you see something that is not right, you look back and you say, how believable is this? Do I have something to tell me that the dates are incorrect? Or if I believe my dates are incorrect, what do I have that could potentially explain to me this IUGR? See, it's really easy and nice and simple when we look at it that way. Now, moving forward, if it wants to move forward, what I put for you, and this is an interesting, also multiple choice question that arises from time to time. It is, what is the expected rate of growth in a baby? And if you see here, from 14 to 15 weeks, the baby's growth is about 5 grams per day. At 20 weeks, it is about 10 grams per day. 22 to 34 weeks, and that is the peak weight gain, right? It's about 230 grams per week. Now, here's where I come in, right? In multiple choice questions, they always use tactics to try and trick you. So I want you guys to answer the question that is below. If the growth rate is expressed as a percentage of increase in weight over the previous week, the maximum growth will be in, and I don't want weeks, I just want trimesters, will be in which trimester? Can anybody answer that question? Anybody wants to answer that question? Let's see. See, what I asked was percentage. I didn't ask about grams. So remember, in the first trimester, the baby starts out with 1 cell, and then it doubles. So that's more than a 50% increase. Yep. You see what I'm saying? So it actually is a percentage-wise. I didn't say grams, I said percentage-wise. The most growth happens in the first trimester, because remember, cells double, right? See how interesting the exams sometimes can play tricks and change. And of course, you know, those of you that have taken exams before will know that the examiners will do things like that. All right. Are you guys so far enjoying the lecture? Everybody's enjoying the lecture?
Jamil, there was a question from Dr. Karim. I think he rose his hand before. So.
Oh yeah, so help me out. If I don't see you raising your hand, I'm trying.
Yeah. So Karim, you want us to? Okay, so I'm gonna unmute you. Okay. Do you still have a question?
Don't be shy. Okay. Come on, ask me. I'm listening. All right.
Okay.
Yes, I will repeat the maximum growth. So.
Excellent.
All right. So when the baby starts out, right, let's say hypothetically speaking, in the first trimester, it is 1 gram, right? Let's say one cell weighs 1 gram. The cells double. So this baby, right, when it doubles, it went from 1 gram to 2 grams. So percentage-wise, it increased by about 50%. But when you look at it, it's only 1 gram as opposed to 30 grams per day in the 3rd trimester. See the difference? So it depends what they ask you, right? If it is maximum weight gain by grams, it is the 32-week mark. If they ask you the percentage of growth is maximum, it is the 1st trimester. Okay? So let's go back to our slides. Perfect. So when we are confronted with a small baby, right? We've decided this baby is small. It's not an error in dates. It's less than the 10th percentile. What we have done is we've done a good anatomic survey. We don't see anything abnormal. We've counseled the patient about her risk of having a chromosomal abnormality. She chooses to do non-invasive prenatal testing. It is low risk, right? And she does, the torch screens. They're all negative. So then how do you manage this pregnancy? So first of all, what do we need to do? Is A, make sure that this baby is safe and does well till we decide to deliver, right? And then how do we make sure that this baby is safe, right? So what do you guys do when you're tired, right? You stop moving, you sit in a corner. Same things, when those babies are no longer happy to be inside, what do? They don't move as much. So your biophysical profile becomes abnormal. Your Dopplers may become abnormal. So the way that we monitor IUGR babies is going to be some form of antenatal testing, whether it's a biophysical profile, whether it's an NST, right? And we're also going to monitor the baby's growth, and we are going to do Dopplers. And those of you that want to understand Dopplers, don't worry, I've got your back, okay? In a couple of slides, we're going to be talking about the Dopplers. I don't know about you guys, but I'm really having fun, right? I'm really happy with how you guys are interacting and how this is going so far. All right, I hope you guys are too. So the timing of the delivery is going to depend on 3 factors: gestational age, Doppler studies, antepartum testing. So now let's go to some of the details. So when we look at IUGR in general, less than the 10th percentile, 80% of these babies, even though they're less than the 10th percentile, are going to be normal. And only 20% are going to have a pathological reason. And we said the 3 things could be placental insufficiency, infectious etiology, genetic, or syndrome. So when I say placental insufficiency, if the vasculature of the mother is not good, it is ultimately going to result in vascular abnormalities of the mother. So what are some of the maternal causes? And we went through them, and this is how I want you to think. What can cause the mother to have a poor vascular system? Renal insufficiency, gestational diabetes, autoimmune disease, cyanotic cardiac disease, hypertension, antiphospholipid syndrome, substance abuse, teratogens, medications. What are some of the fetal causes, right? Infectious diseases such as malaria. Now, a multiple choice question that can be asked about malaria is it is actually the leading cause of what? Fetal growth restriction in the world. That's when it takes into consideration the African subcontinent, right? Now, in our next couple of lectures, what I'm going to do for you guys as well is give you the infectious agent and the fetal effect. Guess why? Because that is high yield for all of the exams that any of you are going to be taking. And also those of you that are not taking the exams, because I know some of you have already finished your exam taking. It's a good thing to have when you're rounding with your residents or your students so that you can ask it, right? Those of you that have taken exams, how many times have you seen intracranial calcifications, periventricular calcifications, right? PDA, you know, right? So deafness, all of these interesting things, right? Now, another thing that can cause babies to be small is also twins, right? Twins can definitely be smaller than the other babies. Now, unfortunately, we really don't have good growth curves for twins, but you anticipate twins to be smaller, right? They're sharing the same place, and some of them, they're sharing the same placenta and so forth. Good news is, we've also got a lecture coming up on twins. And here's what I can tell you, right? Yes, I do maternal fetal medicine, but definitely with my exam revisions, right? I do a lot of gynecology. So if those of you have a specific topic that they would like us to go, you know, that would like us to review and all that sort of stuff, I'm sure if you know, either email me, and I'll give you my email at the end of this lecture, or, you know, even, you know, message me on whatever social media platform, or tell Dr. Better, I am 100% sure we can arrange some lecture for you, okay? I promise. I've got, like I always tell, so, you know, I teach at the University of Louisville. I teach residents and I teach medical students, and they always love it when I'm over there with my computer, because they'll always say, "Oh, I'm sure you can just pull up a slide and show us something about something." So yes, I tell you this, I've got a slide for something, right? So if you guys need anything, you let me know. Okay, so genetic or structural malformations could be, you know, trisomy 13, 18, congenital heart diseases, or gastroschisis. Okay, you know the challenging thing though for gastroschisis, unfortunately, or one of the biggest challenges for gastroschisis, is you don't have an accurate way of measuring the abdominal circumference. All right. We talked about abnormal placentas. So you've got placental insufficiency, abruption, placental chorioangiomas. How many of you have actually seen a chorioangioma? How many of you have seen a chorioangioma? And have you seen it? Okay. All right, sounds good. And then of course you've got the umbilical cord, right? The normal umbilical cord has how many vessels? The normal umbilical cord has how many vessels? 3, right? So if you have a single umbilical artery, you're missing a vessel. So it's a 2-vessel cord. So the way that I look at it, could that potentially be a cause for the baby to be small? Absolutely. Filamentous cord insertion, marginal cord insertion, right? Now, invasive placentation and placenta previa are not usually causes of IUGR. Those of you that want to see what a chorioangioma looks like, all right, we will show you in a few slides, right? So why are we worried about growth restriction? What do you think are some of the biggest problems in growth restriction? What are some of the biggest problems, right? Obviously, intrauterine fetal death, right? Increased morbidity, but there's also an increased risk of neonatal death. They're even talking about, okay, cognitive delays, you know, in the future and so forth. But interestingly, right, the babies that are born small, usually what they notice is after they're born, there is accelerated growth to potentially compensate for the IUGR that is inside. And they have found that those are predisposing factors to things like obesity down the line, right? Type 2 diabetes, coronary artery disease. How many times have you seen a big guy, right, that comes up and goes, "Can you believe I was 5 pounds when I was born?" Right? You wonder. I was almost 5 pounds, so you can see I'm big now. So, all right, sounds good. Okay. So now, also there's a correlation. The more severe the IUGR, the more risk of problems. So the risk of fetal death increases to 2.5% at fetal weights less than the 5th percentile for gestational age, which is why we watch these babies like a hawk. And what do? Do you think it would be a good idea to keep these babies pregnant till the mother reaches 41 weeks or 40 weeks. When I just told you that this baby has an increased risk of IUFD, and we also discussed in previous slides that growth becomes minimal after 40 weeks. So not a great idea, right? Which is why we usually don't deliver these babies at 40 weeks. And we'll talk about timing of delivery in the slides coming up. Okay, there you go. That's a chorioangioma. So this was very interesting. This was actually one of my cases that I recently had to deliver. And this was a chorioangioma that we found on an ultrasound, and it started out to very small. And then one day she came in and it rapidly progressed, right? And if you can see here, see how close this is to the cord here, okay? Can you see how close it is to the cord? And we were worried that if this grew a little bit more, it may impinge on the cord. So we delivered this baby very quickly, and thankfully the baby's doing well. Now, what are some of the other problems of chorioangiomas? Can you think of it? And that's why I always think of things, and it's always, what do you call it? It's always nice to understand, right? Are you supposed to have this amount of blood flow in that area? The answer is no, correct? You're not supposed to have this amount of blood flow. So could that potentially take away blood flow that is supposed to go to the baby? Absolutely. Could that make the baby anemic? The answer is yes, right? So now, if the baby is anemic, there is loss of intravascular oncotic pressure. So what happens to the fluid? It extravasates into the compartments. And that is what is known as fetal hydrops. And that's why I say, you know, we use a lot of fancy words, but when you understand them, they are not very fancy. When I say hydrops, it is just saying there's fluid in the baby. What causes it? Think about it, right? And we'll talk about that in alloimmunization, but think about it, right? If you have a baby that's anemic, there's loss of oncotic pressure, there's going to be extravasation. If you have a pump that is not working well, just like an adult that has heart failure, that's going to cause hydrops. But we're not going to go into hydrops today, but that's kind of an insight into the future. I'm all about understanding, right? And when you guys finish the series with me, and you know, with my students that I teach, whether it's in Kaplan, Becker, or anything like that, they will always know that I always want people to present to me in a system, you know, in a system-based way. And I like them to be organized in how they present and think it over, okay? And it's gonna be simple. When you go through a few things, you're gonna go, huh, I didn't know that that's how that was, all right? These are just some other pictures of chorioangiomas. So now when you talk about symmetrical and asymmetrical, what does that mean? If all of the baby is small, then it is symmetrical. Now, think of it that way. If an insult happens and it affects the whole baby, it is probably going to be symmetrical. Does that make sense? So if there is a teratogen, is it going to say, well, let me just go to the brain, or is it going to go to the whole baby? It's going to go to the whole baby, right? All of the baby. Genetic anomalies, if the baby is intrinsically small. So those are usually going to give you your symmetrical growth disturbances. Asymmetrical usually happen in the third trimester. Baby, very smart. If the blood flow that's going to the baby is not as much, what does the baby try and do? Okay, what does the baby try and do? Tries to save its vital organ. Is there an organ more vital than the brain? Absolutely not, right? Well, yes, the heart is important, I agree, but, but it tries to save the brain, right? So, and here's what I want you guys to remember. Just take this piece of information right now, put it in your back pocket. The umbilical artery is a low resistance circulation, meaning things can go very easily. Umbilical, you know, from the umbilical cord to the baby. Whilst the brain circulation is a high resistance circulation. If that resistance is decreased, that means more blood flow can go to the brain, and that is what is redistribution. And we will talk about it, or brain sparing, and we will talk about it when I show you the Doppler studies. Okay, now, I need to kind of check on you guys for a minute. Is everybody awake? Is everybody awake, and is everybody enjoying the lecture so far?
Jamil, there was a raised hand by Dana. So,
Dana, what? Sure.
So, Dana, you want to ask a question?
question you can.
Dana, you're unmuted. You can.
دكتور ايوه كان السؤال حقي وش الالتراساوند فايندينج في ال previously discussed disease الانجيوما something
Chorioangioma?
ايوه chorioangioma ايش الالتراساوند فايندينج؟
So when you do the placenta, when you look at the placenta, you're going to find a heterogeneous mass, okay? And the placenta usually looks, you know, smooth and everything like that. You're going to see something that's heterogeneous and round. And as soon as you see that on the ultrasound, you'll put color flow to it, and it's going to have a lot of vascularity. Now, what I will do though, because I do have a picture of the chorioangioma, I will 100%, if you remind me, I'm getting old, but I will remember, inshallah, right? Is I will bring you an ultrasound image of it. So one of the lectures that we're giving is ultrasound. And what I plan on doing in that lecture is showing you a lot of ultrasound images, okay? I've got a lot of ultrasound images, okay? I'll show it to you. But remember, the placenta, it looks smooth and nice. If you see it irregular, or if you see lakes in it, or if you see something round, you're like, what is that? Put color, always. I always tell all my residents, my students, always put color. When you're doing an ultrasound, if you see something, put color on it, because it makes a big difference whether it takes up color or it doesn't take up color, okay? Color flow is very, very, very important. Okay, sounds good. Anybody else have any questions? And like I said, please feel free. I'll give you my email at the end, you know, email me. I'll be more than happy to answer your questions as well. So this is how you do a Doppler, right? And before I start, I would like to give a minute's silence and thank this gentleman, because this is the guy that invented Dopplers, right? So now that we've paused, we've given him his due respect, we can move on. Okay, so ultrasound, what does it do? It picks up sounds and motion. Sounds and motion. Blood vessels, what do they have? They have motion. So they go from one place to the other, and motion can change. More importantly, velocity of the motion can change, all right? Again, this is a throw into the future. This is alloimmunization territory, but think of it that way. In anemia, what happens to velocity? It increases, right? So then my velocity is going to increase. So if I measure the peak systolic velocity of the middle cerebral artery, it's going to be high, which is why the peak systolic velocity of the middle cerebral artery is a great way for screening for fetal anemia, right? So change in frequency is reflected, you know, is directly proportional to the velocity of the blood flow within the vessel. Here it is. Red indicates the blood flow is going towards the probe. Blue indicates that the blood is flowing away from the probe, right? And then you can actually Doppler any vessel you want. The issue is the information I'm getting from Dopplering that vessel important or not? Okay, now remember, this is what I've been talking about. The umbilical artery, low resistance. That means even during diastole, it is very easy for the blood to go from the mom to the baby. Low resistance. Middle cerebral artery is a high resistance circulation. So under normal circumstances, when there's no cardiac contraction, there is not a lot of blood flow going to the brain. This is essential, okay? Does everybody understand that? Low resistance means blood flow can go easily. High resistance, blood flow can't go easily. Umbilical artery, low resistance circulation. Middle cerebral artery, high resistance circulation. Okay, we said you can Doppler any vessel. The question is, how useful is it? Now, this is the...
Yeah, we
yes.
have a... Before we go to this segment by Dr. Muhammad, I think he has a question, if we don't mind.
Sure, let me see. Yeah, absolutely.
Okay, Dr. Muhammad, you want to ask your question? Just a second. I'm not sure why I can't mute you. Can you write your question down, please? It's not unmuting.
Well, you know, Muhammad, maybe I'll be able to answer your question as we move on, because I'm going to talk about the Doppler.
Go ahead, Jamil, and you can write your question down.
Okay, I'm sure that the answer to your question, inshallah, will be covered. Okay, perfect. So this is what an umbilical artery Doppler looks like. Okay, now, what is it used for? It is used in an assessment of fetal well-being in usually 3 scenarios. In the assessment of IUGR, in twin-to-twin transfusion surveillance, right? And also, some people will suggest it to be used in preeclampsia, although that is controversial. So, blood flow is measured during systole and diastole. Usually there is greater blood flow during systole, right? And it is usually characterized by high velocity diastolic flow. What do we mean by that? See this? First arrow that comes down, that is the peak systolic velocity. And when you look at an ultrasound image, right, this here, the second arrow, is the diastolic velocity. And see these squares that just went by? That's your diastolic velocity. See how, whether the heart is contracting, not contracting, there is always blood flow. See how I'm making the Dopplers easy for you? Systole, diastole, there's always diastolic flow. There's always diastolic flow, okay? Then, when you move forward and you go, well, what are all of these numbers? I'm gonna easily explain them to you, okay? So we said that this is our peak systolic velocity. This here is our end diastolic velocity. So the SD ratio, believe it or not, is this number divided by this number. Isn't that easy? This number divided by this number gives you your SD ratio. Your resistance index is systole divided by diastole divided by systole again. Your pulsatility index, or your pulsatility index is systole minus diastole divided by the average of the two. Who knew that this was this easy? Systole, diastole, right? So obviously, the less amount you have down here, the less diastolic flow you have, the closer you are to absent end diastolic flow. Perfect? Look at that. There is no diastolic flow. So what is this? Absent diastolic flow. Okay, so some people wanted the previous slides repeated, so I'll just repeat them real quick, okay? See the numbers here? When you draw a line from here to here, you get your peak systolic velocity. You draw a line from here to here, you get your end diastolic velocity. See that? Peak systolic, end diastolic. And if you divide the numbers, you get your SD ratio. And then if you divide these, you minus systole minus diastole, and then you divide it by systole, you get your resistance index. The higher the resistance, the closer you are to absent end diastolic flow. Because remember, We said this is a low resistance circulation. The more resistance, the more problems, the more you are getting closer to absent end diastolic flow. Isn't that cool? All right. Is it now understandable for all of you? Everybody, it's clear for everybody? It really is easy. It really is, okay? All right, sounds good. Let's go to the next slide. See how there, you don't have any end diastolic flow. And then if we move forward, what do we have here? We actually have reversal of flow. So instead of the flow in diastole going to the baby, it is going from baby back to mother. This is not a good situation to have, right? So now we have all these abnormalities. What do we do with them? The answer depends on the gestational age, the pathology, and also fetal well-being. Okay? So if the NST is non-reassuring, it trumps everything. So if I put this baby on the NST and there is recurrent late decelerations, recurrent variable decelerations, does it matter? No, we're going to have to deliver this baby. Does the gestational age matter? No, then we're going to have to deliver the baby. Okay? Middle cerebral artery Doppler. You know why we use this very frequently? Does anybody know why we like to use this very frequently? Because it is easily reproducible. Meaning if we put our sets and guidelines, people can reproduce it in any ultrasound setting. So now we have something that is easy to reproduce. We've got nice numbers that tell us multiples of the median. And based on the gestational age, if the multiple of the median is above 1.5, then we know that the baby is potentially anemic. So something that is easily reproducible, tests velocity, can tell me brain sparing. Wonderful, wonderful test to do, correct? And this is how to do a correct middle cerebral artery measurement. Remember, one of the most critical things is to do the zero angle approach. So when you actually don't do your Doppler gate on a zero angle, and it's on one side or another side, you are going to falsely have an abnormal peak systolic velocity or a middle cerebral artery Doppler. Okay? Sounds good? All right. Now, when we talk about brain redistribution, see how if we look here, and I will show you in a minute, see how here, do you have a lot of diastolic flow? You do not, right? So that is a normal middle cerebral artery Doppler. Once your middle cerebral artery looks like your umbilical artery Doppler, guess what happens? Then you have brain sparing. And see how the PI or the pulsatility index had to be above the 95th or the 97th percentile for you to say it's elevated? In a middle cerebral artery, usually if your PI, right, or your resistance index is less than the 5th percentile, then it is redistributed. There is another way of measuring it, which is the cerebroplacental ratio, which is simply the PI of the umbilical artery divided by the the PI of the MCA divided by the PI of the umbilical artery. If it's less than 1, there's redistribution. Okay? So these numbers now are no longer ambiguous for you, whether you're in residency or and all that sort of stuff. And I always sit with my residents and sit with my general attendings, and we talk about these numbers. And once I tell them or give them a little bit of an insight, they're like, oh, it makes a lot of sense. Now I understand. And then when it's seen in a report, it's no longer what are they talking about, right? So increased resistance in an umbilical artery, not good. So if you see the 97th, 98th percentile in a PI of an umbilical artery, not great. If you see the resistance go down in a middle cerebral artery, not good. All right, there you go. See, this looks normal. This has a lot of redistribution. Normal redistribution. All right. Has anybody seen this waveform before? It's a ductus venosus. Has anybody seen that waveform before? Okay, so the A wave is here. You're absolutely correct. Perfect. So this is a ductus venosus. The ductus venosus is actually the closest vessel going into the heart. So when this ductus, now, unfortunately, it's not standard of care and not everybody uses it, but we use it in cases of extremely early IUGR, where we really do not want to deliver the absent or reversal of flow. So we look at the ductus venosus. And the things that we look for in the ductus venosus are the peak systolic velocity, the peak diastolic velocity, the isovolumetric relaxation, and the end diastolic velocity. Now, I don't want to go into the ductus, the ductus, the wave, in detail, but this is what a reversal looks like. See? This is not good. Once you see this, this is an indicator that this baby could die within the next 24 hours. All right, so all fetuses with IUGR, we agree, should be enrolled in fetal testing, serial umbilical artery Dopplers. Now, here's the controversial part. Here is the very controversial part. When we don't, the ductus venosus is not routinely done in IUGR. It's only done in very, very small babies, very small babies. Now, like I said, a lot of hospitals may do it, but we just have to use it with caution because it's still not considered the standard of care. It's a good thing to do. It's good to have it. It's good to utilize it. But again, I would take it with a little bit of caution. Okay, so the question is, when do you start doing fetal testing for IUGR? What is the answer to that question? When do you start doing biophysical profiles and NSTs? When do you do biophysical profiles and NSTs? At what gestational age? And the answer to that is really complicated. It is done at a time where you are prepared to intervene and deliver the baby. So the earliest that most people will start with, so what we do, so here's the deal. When I was doing my fellowship, we used to start doing NSTs from 24 weeks with IUGR and start doing biophysical profiles at 26 weeks in my university where I did my fellowship. In the hospital that I'm practicing in right now, we do weekly Dopplers, but no NST and no biophysical profiles from 24 weeks to 28. And we start doing fetal testing at 28 weeks because we believe that as long as the umbilical artery Doppler is normal, we have no indication to deliver. Now, it becomes very tricky and very dicey when you have a 23 or a 24 weeker with absence or reversal of flow. All right, it becomes very tricky, but that is usually within the realms of MFM and it should be individualized, all right? Sounds good? The good news is we're almost done. So usually, uncomplicated IUGR are delivered at 38 weeks, uncomplicated. If they have oligohydramnios, abnormal umbilical artery Dopplers, or maternal risk factors or other comorbidities, they are usually delivered somewhere between 34 to 36 weeks. And when I say abnormal umbilical artery Dopplers, I'm excluding absence and reversal. This is when the PI is elevated. If there is absence of flow and fetal testing is reassuring, then we deliver at 34 weeks. If there is reversal of flow, then we deliver at 32 weeks. But usually, once you hit absence and reversal of flow, you're supposed to manage them inpatient, where you do NSTs twice a day, BPPs daily, make sure that these babies are okay to continue. All right? Sounds good. All right. Does anybody know what this is? This is one of the cool, so just to give you an idea, this person actually, this patient, every time she sees me, she always calls me the nerd because I was so excited so we diagnosed this before the cesarean delivery, right? We knew this diagnosis before the cesarean delivery, and we stopped in the middle of the cesarean delivery to take this picture, all right? And she called me the nerd, because I was probably more excited about the vessel that I was seeing than the cesarean section itself, right? it just tells you, right? What medical doctors get excited about is weird and different, right? So this is actually, it was actually a vasa previa, right? It was a vasa previa, and we knew it was a vasa previa. And when me and my colleague were doing the cesarean section, we said, hey, let's try and keep the membrane intact and see if we can see the vessel. And we did that, all right? And look at that, isn't that cool? Now, how many of you want to see what that placenta looks like after delivery? You know me by now, I'm gonna have a picture of it, right? Look at that. So look at the umbilical cord here, right? Can you see it? And then suddenly there's no Wharton's jelly around the vessel here. So this was actually a bilobed placenta with a velamentous cord insertion, which means that the cord was inserted to the side and there was no Wharton's jelly covering the umbilical cord, and this was covering the cervix. So now here's an interesting thing. If you ever do a vaginal ultrasound and you see a vessel on the cervix, is there a way of making sure that this is a fetal vessel? Does anybody know how to do that? That's a cool, neat trick. Yeah, absolutely. If you do a Doppler, it is going to show an umbilical artery Doppler waveform. And when we were doing her ultrasound, we Dopplered that vessel and you could see it, right? But isn't that like, it is amazing. We found this before the baby was born. We knew it was there. We took her for a C-section. And, you know, every time she comes to our office and she shows us the baby, you know, she looks at us and she goes, this baby potentially would have not survived if she had gone into a vaginal delivery, all right? So she calls me the nerd. She really does. Every time she goes, where's my nerd friend? Come over here. So it's interesting. But here's the rest of the placenta. Now, does anybody know what this is? Right, so this is the placenta. And does anybody know what this sign is?
Jamil, there's a request to repeat a slide of the follow-up later on, inshallah, if you notice that.
Which slide?
In regards to the follow-up later on, we're going to go back and we're going to ask her to ask the question, okay?
Sure, absolutely. But see, look at this. Can you see? This is actually called, the sign that you guys are seeing is called the tornado sign, because normally the blood vessels will go in one direction. See how this blood vessel twirls in multiple directions, right? Do you want to see an even cooler image of this? So I actually tried to 4D the image here, and look at what we got. If I can, look at that. That's a 4D image of a placenta accreta, and you can actually see the vessels here, how they're invading into the wall of the bladder. Look at that. Isn't that cool? And you can see the lacunae here and the vascular. You can't see the lacunae, but the vascularities are in the lacunae, but you can actually see that there. Very cool. And then this was actually her cervix. Look at how vascular that cervix was. Scary, right? So guess who got a hysterectomy? Right. Okay, perfect. So I'm actually done with my lectures for today, but of course I'm more than happy to answer any questions for you. Okay, so please tell me which slides you want me to go back to, or if there's anything that you guys did not understand.
They want to go to the middle cerebral artery area. Can you go back to the middle cerebral artery, please?
Sure, sure, absolutely. Okay, so here's the middle cerebral artery, okay? So just to kind of show you, when we look at the umbilical artery, can you see that? Can you see the umbilical artery? Let's see if I can see what the question is. Okay, sure, I will talk about mode. See how the diastolic flow is a lot, right? That's a typical umbilical artery. Then when you look at a typical middle cerebral artery, it doesn't have a lot of diastolic flow, right? And when we do a middle cerebral artery, there is two things that we look at: how much diastolic flow there is and how tall this is. The more that this is tall, the more we have peak systolic velocity, the more likely the baby is anemic. That's one aspect. But if the diastolic flow is big, then there is more likelihood that this baby has redistribution. Now, the way that we can calculate redistribution is by looking at the PI. If the pulsatility index is less than the 5th percentile, that's redistribution. That's one way of calculating it. Now, if you want to calculate it through another way, you can calculate it by dividing the PI of the middle cerebral artery with the PI of the umbilical artery. And if it's less than 1, that's redistribution. Okay, now the reason we use the middle cerebral artery is because it is between 2 bones, meaning it is easy to find, easy to reproduce, and we have been using it now for a good number of years. So now we have graphs to tell us at what peak systolic velocity based on gestational age are we above 1.5 MOMs. Makes sense, right?
Very good. Now, I think there are other questions. So
yes. So mode of delivery. Okay, because I saw about that. So it's all about an absence, and so let me put it that way. IUGR by itself is not an indication for a cesarean. But if you have a severely IUGR baby with absent end diastolic flow, with an unfavorable cervix that is remote from delivery, that you feel because the baby is severely IUGR with absent end diastolic flow, the baby is not going to be tolerant of labor, you can absolutely offer her a C-section, absolutely. But it's also counseling. If she says, I would like to try, there is no absolute contraindication. As long as the fetal heart tracing looks reassuring and looks good, you can say, we will try. However, we will have a very low threshold to go and proceed with a C-section. And we've done both, but I'd say the majority of patients that I've seen with reversal of flow, small baby, 28 weeks, 29 weeks, that baby's not going to tolerate labor. It is not. And a C-section is probably going to be the safest out of them.
There's another question about the mode of delivery when you have an end and reverse end diastolic flow.
Again, we counsel the patient, the majority of them, if, you know, it all depends. So if the patient is 4 or 5 centimeters and she delivered 7, 8 babies and the tracing looks good, we can potentially individualize and deliver her vaginally. But the overwhelming majority are not in that, they're not in that boat. So unfortunately, they end up going for a C-section. But it's all about counseling, right? It's all about counseling. Now, the question about accelerated lung maturity, you have to remember that lung maturity is associated with steroids, right? And cortisol secretion and all that sort of stuff. And a lot of times they feel that stressed babies secrete more cortisol, so they're more likely to have better lung maturity. But in the end of the day, okay, this is a fact that we know. A baby that is 2,500 grams at 28 weeks, right, does worse than a baby that's 2,500 grams at term, okay? So even though weight is important, but also gestational age factors into, factors into it. And there's a reason why, Hannah, I did not go into the frequency of BPPs because it's controversial. I can tell you what the majority of people do in the United States. Most people in the United States will start doing NSTs at around 26 weeks, weekly, along with Doppler studies. And then starting at 28 weeks, if the fetal rate of growth is between the 5th and the 10th percentile, they will do weekly testing. If the fetal rate of growth is less than the 5th percentile, they'll be doing twice weekly testing with once weekly Doppler studies for both, right? And that's what we do in our institution. So if it's less than the 10th percentile, we do fetal testing from 28 weeks, once weekly. If it's less than the 5th, we do it twice weekly.
There was a question by Dr. Hannah, and I think she wrote it down. I'm not sure if she has another question or not. She was, how frequent should we do biophysical profile and NST?
Yeah, I just answered that.
Okay,
just
good.
now.
And there's also a raised hand by Dr. Muhammad Asiri. So let me try to unmute him.
Sure.
Can you unmute him من عندك? Okay, now I think he's unmuted now. Muhammad, your mic is on.
Dr. Jamal, thank you for the lecture. I have a question regarding uterine artery Doppler early in pregnancy. Does it predict IUGR or not?
So it depends. The studies are conflicting, right? So what we do, or what I can tell you what we know, is unfortunately the umbilical artery Doppler in the beginning is a high resistance circulation, and the resistance goes down. But better, you know, so there are some other predictors for IUGR, such as unexplained AFP. That is a big predictor. There are other people that use the, and I may have misheard your question, but the uterine artery is very controversial. And we did a lot of studies on it when I was doing my fellowship, and my mentor in fellowship swore that it was the best thing ever. But if you look at the studies, they're conflicting. They're very conflicting. But an unexplained elevation of the AFP is definitely a risk factor for IUGR.
There was another question by Hannah.
Yeah, so Hannah, so the more important part of it is to do the umbilical artery. Whilst the middle cerebral artery, the way that we look at it, it actually consolidates whether your IUGR is true. So for example, if you do an umbilical artery Doppler and it's showing increased PI, and it shows redistribution of the middle cerebral artery, then you know that this is probably not constitutional IUGR. The literature says that you should do both, right? But you shouldn't take management decisions just based on an abnormal MCA, okay? But there are also some studies out there that show you the typical progression of an MCA. You actually have the time where it redistributes, and then there's a period where it improves, and it's actually more concerning when an IUGR baby has redistribution that goes back to normal. And then after that, in a lot of these babies, you also see the peak systolic velocity goes up. And when the peak systolic velocity goes up, it's usually because that baby is not able to oxygenate the brain very well. So IUGR, we manage as an outpatient unless we have concerns about abnormal Dopplers. Once they have absent or reversal of flow, then they are managed as inpatient. If they have that absence or reversal of flow after 34 weeks, they get delivered immediately. If they have reversal of flow after 32 weeks, they get delivered immediately. Other than that, they get managed as an outpatient. Okay, Honor X, I'm not sure if I understand your question. Oh, the role of the PAPA. Okay, again, it's reported. If a PAPA is, so you have to remember all of these, whether it's a quad screen or a PAPA or any of that sort of stuff, they could, you know, what do you call it? They're all neurotransmitters that are originating from the placenta. So if they're abnormal, they usually indicate an underlying placental abnormality. So the suggestion is in any of these, they should be managed, you know, with estimated fetal weight of 480 grams with reversal of flow. Is that somebody that you think the baby's going to survive? Not likely. So then they say, well, in these cases, doing a ductus venosus, right? And the way we used to do the ductus venosus, you'd actually do the calculations and it would give you zones. And as long as the baby was in the safe zone, and you knew that the baby's likelihood of dying in the next 24 hours was low, and you would do it every 24 hours. Now, if you get reversal of that ductus waveform, it doesn't matter whether the baby's 24 weeks, 25 weeks, you know that fetal death is impending, and then at that point, you should deliver. But after that, you know, beyond 28 weeks, its use is very controversial because you're supposed to judge your delivery and whether you should deliver them or not based on your fetal well-being and your Doppler studies. Did that answer your question? I would say we don't use it after 28 weeks. We use it in that critical period between 24 to 28 weeks, only when we have reversal of flow. Okay, so let me see if I've missed any. No, so I don't do it for all. I counsel all patients for IUGR and TORCH. So when I have a patient that is IUGR, I'll go through the causes of IUGR, and I will offer to do it. And I'll say, look, I do. Now, definitely if we see calcifications, if we see anything to suggest an infection, then we'll definitely push for it. Other than that, I will say, look, this is one of the causes. Would you like me to screen for it? Just like I would do for aneuploidy. I will say, I don't see anything in the baby to suggest an aneuploidy. However, would you like me to do, if you counsel the patient in extremes of gestational age, you can use it. Is there a cutoff for AC growth that I need to take the management and for what? So if I understood your question correctly, there are some people that say, even if the baby is appropriately grown, anytime your AC is less than the 3rd percentile, you can consider that, okay? You can consider that as IUGR. All right, I hope, Amar, I've answered your question. AC less than the 3rd, even if the baby is appropriately grown, is considered IUGR. Okay, so 32 weeks and beyond, if you have reversal of flow, delivery. 34 weeks and beyond, and there is absent of flow, delivery. Anytime in IUGR, if your fetal testing is non-reassuring, equals delivery. Perfect. We don't do pre-viable Doppler assessments because we're not going to intervene. And like I said before, usually early Dopplers are going to be abnormal because the resistance is still high. Usually 24 hours. But you have to think about it that way, right? If you have an abnormal DV and you put a patient on continuous monitoring to give magnesium sulfate, that is absolutely acceptable because guess what? The patient is on continuous monitoring, and at that point in time, your NST will tell you whether you can keep her pregnant or not. All right.
So I think for the time of Dr. Jamil and Ada, I think we're going to have another 3 questions, and I believe we.
But here's the deal. I'm going to share my my email. So. You know, this is what I'm going to do. I don't know why it's, yeah, so here, I'm just going to share my email with everybody. And then that way, if anybody has any questions, they're more than you know, they can email me at any time and I'll be more than happy to answer their questions. And even if we set up some, like, I don't even mind talking over
set up a Q&A kind of session. Later on, yeah.
Here you go. I put my email there. Okay. Yes, a fibroid can give you IUGR. Anything that can share the baby's blood flow can give you IUGR. Right. I really hope you guys enjoyed the lecture. I mean, some of the questions that you guys asked were very, very, very intelligent, very good questions. And to me, anytime I get this amount of questions, it tells me that you guys were very engaged. I caused some controversy to stir up all these questions. I really had fun. I really enjoyed it.
Really, it was an amazing lecture, Jamil. Thank you very much. It was informative. I really enjoyed it myself. And I had a lot of comments from senior consultants who sent me, and they really actually found it as well joyful and beneficial.
Well, I'm glad. A lot of those senior consultants are my good friends. I miss you all. I really do.
Yeah. And I think we're going to wrap it up for tonight. Hopefully we're going to see you next week, and probably you might have a few questions that you can email Dr. Jamil about. And maybe if there were a lot of questions, Jamil, we can open up later on a session of Q&A sometime suitable for you. And yeah. So next lecture is going to be?
I don't have the schedule in front of me, but I think it's either aneuploidy or alloimmunization, one of the two. Now, alloimmunization is really a lecture that I really advise you all to attend because there's going to be a lot of understanding in that lecture. And you know what? Every single resident or student that I've given it to has said, oh, okay, now it makes a lot more sense. I promise it's going to be very easy once we talk about it.
Then until then, inshallah, we're going to see you next week, guys. First of all, I would like to apologize for the difficulty that we had faced in the beginning, and we hope that next week it's going to be much smoother and easier for everyone to join. We are looking forward for everyone to join easily, and hopefully by that, next week we're going to, I think, have the email shared to whoever registered earlier, so you can have it time ahead, and hopefully we're going to see you soon. So thank you very much, everyone. Thank you, Jamil, and good night.